Hi, good morning, everyone. It's a pleasure to be here in this auditorium again, and I always look for reasons to come back home. It's like a bird that flew the nest, but always remembers the path back. And it's just wonderful to come and meet old colleagues, friends, and and I now the guys who are sitting on the front row and the second row, they are not students. They are colleagues and they are actually teachers. And to be honest, they are my go-to people when I have a clinical query. And I'm sure everybody here would say that they would have received a call from me sometime or the other asking, what do you think is the best way forwards to treat a clinical situation? So it's a constant learning experience as we go through our careers, and we learn from each other. And what Dr. Dhiman just said about emergency services, 24-hour services, I think the point being made is that we are clinical radiologists. And if we are clinicians, we have to offer clinical services. And I think you got a tremendous example today of the talks that you heard. You saw the thinking interventionalist. They are not proceduralists. They are now physicians in their own rights. That's exactly what all of us should aspire to be. What we saw in the 3, 4 lectures that we heard, it's always just re-emphasizing the fact that we have to manage our patients. But, and I'm glad we've reached this point. And now I give their examples, everybody up front here, front row. And I give these examples to all students who still come to me, that just follow them. Just follow them and you will make a tremendous career. Just be like them. Try to emulate them. And that's the way to go. But it took us some time to reach this point, and we started many years ago. We are now in our fourth decade of interventional radiology, as far as I'm concerned. And I thought we'll take a walk through the biliary tract to try and see how things moved across so many years. So historically, we all know things started in 1974 for the first time when biliary drainages started. So we were not very, very late. We did our first biliary intervention in 89, which was 15 years after the world thought about doing a biliary system. These were the kind of machines that we worked in. The first one is that overcouch tube, which today, as I was walking and I just peeped into room number 3, this machine is not there anymore. So finally, it's found its resting place, I think, after giving us a lot of service. And the other machine is the machine which was in room number 2. Now, I don't know what exists in room number 2, but that's actually the machine in which we did our first biliary intervention. You can imagine the overcouch image intensifier is on top, and we are bending over, virtually not seeing the field in which we are working, and we were trying to do an intervention there. And what we used to do was, we used to do an ultrasound guided puncture in the ultrasound room. By the time we would bring the patient here, the needle is anywhere but where it should be. And again, we would take him back to room number 7 or room number 8, where the ultrasound machines were. So that's the way we started here in SGPJ, but it was an era of passion and an era of willingness to work and learn. We gradually moved to this modification there, and we got a C-arm, and we used to keep a fan running underneath that table to keep the tube cool, because it didn't have an oil cooling system to keep it going when we were doing our non-vascular interventions. We got a chance to do some work in the DSA lab as the lab started improving. And you can see there's Ashish there, and there's CP Chauhan there. And Shravan, I think, is sitting in the auditorium, and he can recognize himself in the far distance. And this is how the modern day IR labs look. And that's how the recognition of IR is actually manifested by these pictures. The world realizes that the IR is as good as the machine on which he or she is working. So it's imperative that you get equipment, state-of-the-art equipment, and then you can do better than the best. And that's what we are working with in our hospital currently today. And that's the hybrid OT, where we always go and do procedures sometimes which are required intraoperatively or perioperatively. So equipments make a big impact, but you have to start. And the start is to get into the bile duct, to do anything in the biliary tree. So originally we used to do PTCs and then find an appropriate duct and then try to do a puncture under fluoroscopic guidance. But then, and one of them was this patient. I don't know if any one of you was here when this patient we did here. This was somebody who underwent hepaticojejunostomy, and the surgeon said, great job done. You can see the right and the left ducts and anastomose nicely draining. But this patient was very sick and coughing out bile. So something was certainly wrong. And obviously wrong it was, because if you see that the place where the right lobe of liver is, there's no cholangiogram there, because the surgeon had mistaken the segment 4 duct and the left lateral duct as the confluence and had missed out the entire right duct altogether, which had ruptured into the perihepatic space, gone through the pleura and into the chest, and she was coughing out bile. So we just injected through the sinus and we got that cholangiogram and we knew what was wrong. So then we talked among ourselves that time, and we had something called detachable balloons that Dr. Phatke used to use for his neuro interventions. So we borrowed that from him and we detached that balloon in the sinus tract, which was leading up into the chest, to try and at least seal the leak into the chest. Did a diverting PTBD. The chest cleared. You can see that resolution of the picture. And once the patient clinically improved, went to surgery, and Dr. Sadiq Sikora was the GI surgeon here at that time. He did a hepatotomy to segment 5 and did a segment 5 anastomosis with the jejunal loop. So this lady who came in nearly gone and dead went back walking and quite well. That was also the era when surgeons would often intervene in the biliary tree and place T-tubes. And sometimes there were stones that were left behind. If the stones were left behind, we would invariably catch them and either pull them out, or we would push them down through the ampulla into the bile duct and just clear them using the T-tube access. And this was a patient in whom there was a collection of biloma. The endoscopist did an injection and they filled the lower bile duct, the collection, and then the contrast going up into the intrahepatic tree. So we used a percutaneous track into the biloma, and then we cannulated the lower limb and the upper limb of the biliary tree and percutaneously inserted a T-tube to re-establish connectivity of the upper system with the lower system. Then very foolishly after that, not knowing what this was all about, we deployed metallic stents, which I think all of us would certainly say was definitely the wrong thing to do. And at that time, in our eagerness to treat things non-surgically, this was done. So we've also got to learn when is right, and when is overdoing wrong. And we've got to be alert to all the medical data, and we've got to keep ourselves educated and updated about the clinical data that justifies the procedure. Very much so what, like Amar was showing, a series of papers that he's published, which we refer to really try and make up our minds whether what we are doing is right or wrong. An imperative to all of this is understanding the biliary anatomy. You've got to understand just hitting the bile duct is not good enough. You've got to understand that in each segment of the liver, there is an anatomical relationship of the portal vein, the bile duct, and the hepatic artery. And in segment 2, it is different, with the bile duct being superficial. In segment 3, there is a distinct portion where the bile duct bridges over the portal vein. Otherwise, for majority of length, the portal vein is always superficial to the bile duct. In segment 6, you will find that the bile duct is more lateral, whereas in segment 8, again, similar to segment 3, there is an area where you would get the bile duct superficial intact. And we also got the opportunity, as you might have noticed, that this ultrasound transducer has no cord to it. So it's a cordless ultrasound transducer, one of the machines that we were testing for Siemens, as we are a beta site for their development materials, because we thought that this is the kind of probe which is going to be really useful for IR. So we got them to make this, and they sent it across to us for using. Not having a cord attached to the ultrasound probe makes it so easy. And therefore, the next thing we've got to do is to puncture those bile ducts without hitting the artery or the vein. That is the key. And ultrasound visualization and real-time evaluation is the best thing. But along with that came the armamentarium. We were always using 18 gauge needles, and you can't blame a guy using 18 gauge needles and small ducts to always come clean into the bile duct. But the newer micropuncture sets and the access sets have now enabled us to use very skinny type needles to get into virtually non-dilated biliary systems. And all ducts can now virtually be accessed, is what I'm trying to say. And once you're in the bile duct, then you've got to see that when you've injected contrast, you see that tenting thing that's happening on the first image. So the tenting of the bile duct is a tactile feel. You've got to feel it in your fingers. And that's where you've got to adequately release the thrust that you are pushing forwards to not go through and through the bile duct. That's the secret. If you don't puncture the far wall, your wire will always stay in the bile duct when you send the wire in. Now, if all of this requires work in fancy equipment, sometimes we will have to go to very sick patients. And this was a patient who was in the ICU, so critically sick and cholangitic and hypotensive that he just couldn't be moved. We had this reference image, but we knew that the bile ducts were large, so we went down to the bedside and did as many biliary drains as we could. And there was a huge burden of hepaticolithiasis, which we eventually then cleared out once his sepsis improved. But we also, in this path, also came across strategies of biliary drainage. Initially, we used to think we've got a catheter into the bile duct, that's a great achievement. But now all of us realize that is certainly not and should not be targeted as the end point of treatment, because in many situations where we are doing palliative management, you have to give quality of life importance. And with external drains, there are invariably situations of the catheters accidentally falling out, getting displaced, respiratory movements, creating loops outside the liver surface. And until you have an adequate length down the bile duct, would these catheters only stay stable? Otherwise, there's a very high chance that you would lose them. So we tried to make up devices which would improve anchoring of external drains. So we thought that let's take a Malicot catheter and make multiple flowers. And probably this will give it some support. So this was something which we improvised on table to try and use external catheters with a slightly better self-holding force inside without having to use the expensive locking systems. And this is another thing that can happen with external drains. And this was, I think, our probably second PTBD at SGPGI in '89. And we had used an angiographic catheter for drainage because we didn't have any drainage catheter. So this was a 6 French catheter and it broke off after a few months. So we went fishing after it. And then you've got to also learn how to handle the issues that come across. So one of you asked the question to Amar, what happens when things bleed during the BRTO? Absolutely right. What happens when catheters break inside the bile duct? You have to fish them out. And it's our responsibility that we do it. There are other issues related with external drains. This you can see is a gallbladder cancer which has come along the PTBD track onto the skin. And these are maggot infestations at PTBD drainage sites when the patients go home to rural areas and cannot take care of them. So, but the most important, if you're palliating, is short-term palliation and therefore give them good quality of life. Don't give them Eurobags outside. At least achieve internal drainage. And that's what we used to do in these early interventions that we were doing here in the early 90s. And therefore, to do that, you've got to navigate. You've got to find your way through the strictures. So I think keeping a jug with hot water and steam is probably something which all of us probably still have in our labs. And that allows us to shape our catheters and steam them and make shapes of the nature that you think is appropriate for the stricture that you're managing. And I just sort of put together a bunch of catheters that we still have in our lab, which we have shaped into these different ones. And I encourage our young IRs to just make the shape, select the appropriate catheter. My job is usually to do the shaping, and my colleagues are the ones who are actually doing the clinical work. And just to show you one of these strictures in a liver transplant where the bile duct comes so low, and then you've got to reverse loop it back up and then take it down because of an angulation. So those catheters came in handy. And the other thing is not to give up. Just to show you a patient I don't know how many times, this must be at least more than 10 times, we tried to cross a biliary stricture. The patient was also with us. She was willing to undertake so many attempts. We were willing to keep trying, and finally we made it across. And I still don't know why it took us 10 attempts to get across. But these benign biliary strictures are sometimes very, very notoriously tough. So when it comes to self-expanding metallic stents, we must, and I must bring up the picture of Sumit. He and I joined SGPGI together in 1989. We came in for the interview at the same time. In fact, what I can say is that I came to SGPGI before him, because when I was doing my MD in KGMC, our head of department there was something in administration in SGPGI. That was somewhere around 85. And I think he was scared that he was driving through a meeting to SGPGI, and he was scared that if his car breaks down, what will he do? So he needed one more guy, and I was the postgraduate on hand. So he put me along in his car and he brought me here. And that's when I saw this place for the first time. There were no roads, in fact, leading up to this place, and there's a shack in which there was a meeting trying to develop what the building was going to turn out to be. But Sumit and I came in here in 89. He had a passion which I think even I cannot match. And even at that time, he was so far ahead of all of us. In his spare time, he would sit in his room, just rigging up things. One day I went in there and I saw, what are you doing? So he had some kind of batteries that he had rigged up. He had taken some gallstones from one of our surgeons, and he had created an electric circuit, and he was trying to break the stones. And this was somewhere around 92, 91, 92. He was that far ahead, thinking about how you can create devices to break gallstones, which later, of course, now is standard of the day. And he's now in Norway and pursuing clinical and research work there. And so he's somebody who I must give total and full credit to launching me on to where I am now today. And this was our first metallic stent that we did. We felt very proud, see a gallbladder, let's deploy metallic stents that we made. And the very next day, all the pieces had migrated. You can see one went down the bile duct, two fell into the cavity, but we didn't give up. If you realize on the first picture, the cavitating gallbladder malignancy has also fistulized into the duodenum. So we said that let's use that path if we can't keep the natural path. And we put a plastic stent on the right side going extra anatomic into the duodenum through the fistulous communication, and the left one down the native system. But we had to go back to plastic stents. And this was the stent design that we came up with. And this was the design because that allowed us to do some crimping rather than welding. And then we went, Sumit and I went to Japan for a year, where we really got a feel of what IR was all about. Dr. Ishiguchi spent a year with us. He was the interventional radiologist there, where I had some good times. And this was some of the lab work that we were doing. So there we did some effort in trying to ablate liver tissue using laser. And then we developed esophageal stents, which we tested in rabbits. We did fallopian tube occlusion in rabbits, trying to develop systems of how we can occlude fallopian tubes, because we thought that that would be a great thing that India would require. And then there was some in vitro work about how to deliver stents and different speeds and different diameters, and how fluid is flowing would impact on delivery of stents. So we did some in vitro work there trying to develop what is the optimal way to deploy self-expanding stents. So it was very interesting. We came back here. You can see Manoj Kathuria is now the program director for IR, I think at Dallas, if I'm not wrong. And you can see him there deploying a metallic stent through a long sheath. These are big sheaths. That's the stent which is loading. We used to load them manually inside and then cut the tip of the dilator and make it as a pusher, and we would push it through. And then after pushing it through, we would just pull the sheath back, and then he's placed the external catheters. This was our little factory that we had, where we had different kinds of gadgets which we used to use to really make the stents. And the stents were made from wires that we had gotten from Japan, meters of it. And then we thought that why not improvise? So we thought, let's make a fenestrated stent. We said, why do two PTBDs, one right, one left? Why not create a fenestration in our stent, place the fenestration to the other side and go from one to the other side? So that's what we also were able to develop, and we tried to then do bilateral drains using what is now called the standard T, where the T reconstruction is what we had come up with at that time, and we were doing using that fenestrated stent. Then we said that the problem with the stent is that the tumor comes in. So can we put a covered stent inside? And the covered stent, we used PTFE, but it became so bulky, it became impossible to deploy. So then we created a system in which this was a type 1 block. So what we did was we took one unit of the stent on top, one on the bottom, connected it with some thin wires, and then sutured PTFE on it. So if you can see the middle picture, you can see a little bit of metal on top, little bit of metal on the bottom, and there's no stent in the middle. And it's highlighted in this picture where you can see only metal on top, metal on bottom. In the middle is actually the PTFE tubing. So we deploy. So it was a two-piece stent. First, the coverage was deployed, and then a self-expanding stent to expand the PTFE inside the patient. So we constructed the covered biliary stent inside the patient by using a two-body system, and this is what the covered PTFE stent achieved for us. Hilar disease, cholangitic patients, you have to drain everything. You don't know what is infected and what is not. A lot of hard work used to go in that time because we had these catheters which were 8, 10 French, 12 French, and it was a tough time and tough for the patient also to get so many tubes down. But we also knew that we couldn't get so many stents down. So we used to literally reconstruct the hilum, each individual segmental duct coming to its parent duct, and finally one stent going down, taking all of it down. But in the hepatojejunostomy situation, we knew we could be more liberal because there it was a surgically created anastomosis, multiple stents, all of them going across into the gut. But there were also issues, and you've got to be careful. And we had our bits and stories, stent migrations, and then you've got to just add them and extend them. Biliary hilar disease, it's important to understand the anatomy. So I think the use of an MR and a perfectly done ultrasound and CT is so imperative. Getting into the bile duct is so important. You can use snares, one from the other side. If you can't cross over, can't go down. The effort is try to crisscross some of the stents on top. Don't send everything down because you will just clog the bile duct with too much metal inside. So we were able to then reconstruct, like this patient who had a lot of sepsis on both sides. There was an endoscopic stent that somebody had deployed on the right side, and obviously now we knew that there was cholangitic abscess on the left, pus coming down the papilla on the right. So we knew both sides were infected. So we made a series of 2 Ts because there were just too many ducts. So there were 2 sets of stents crossing from right to left and 2 sets of stents which were going down. So we were able to do many more systems than the number of PTBDs by reconstructing using the T configuration. So this was a double T that went in. And similarly, this patient, again, similar situation. So you don't give up. Keep working as hard as you can. Get them drained, especially when they're cholangitic. This is not the case for somebody whom you're trying to treat only for pruritus or only for jaundice. But it required a lot of reconstructions. This patient lived 18 months and her stents reoccluded. Then we put plastic stents through them because the endoscopist said that I can't put so many endoscopic stents from below. So we redid the percutaneous. They also blocked. And then at the end, she went back on internal external catheters. But 18 months, out of which I think 15 months, she was catheter free and lived good quality of life. Sometimes what happens is you deploy a stent and the stent blocks and the stent keeps blocking. So we always wondered what was happening. And we just theorized that was it food refluxing up, or was it tumor necrosing, or was it blood clots? So then that's where cholangioscopy helps. So cholangioscopy actually allows you to see inside, and now you can see the tumor. So you can see the tumor actually bulging. That white stuff is the tumor there. So the tumor bulges in through the interstices of the metallic stent. So we knew that what you need to do is put in a covered stent. So that's the cholangioscope going in percutaneously. You can see us through the access sheath. Under vision, you understand the problem and then solve it. But sometimes you have to do more than just staying in the bile duct. A patient who had endoscopic stent came back with duodenal obstruction. And for some reason, the endoscopist couldn't manage this duodenal block. It was a huge pancreatic mass, large peripancreatic lymph nodes. The whole part of the C loop was actually involved. As you can see that C loop over long lengths is diseased. So we came percutaneously, secured access to the bile duct, then came down perorally, and we said, okay, we'll construct the duodenal stent. So we deployed a series of duodenal stents to reconstruct the C loop of the duodenum, and then went ahead and deployed the biliary stents to give this patient palliation, not only for the biliary issue, but also giving him the option of eating perorally again. To try and keep our catheters and stents patent, we believed that we've got to try and kill tumor in and around the bile duct. So intraductal brachytherapy was something which we believed in at that time. And these are pictures from SGPGI here, where we developed brachytherapy as a tool through our PTBT catheters. And we had 85 patients at that time, where we saw that if you were not going to use the brachytherapy, the survival was definitely lesser as compared to if brachytherapy was used, because the patient's stents clog later. So the sepsis, which actually takes the patient away at some point of time, occurs much later. So you can see that the overall survival in the brachy was definitely superior to the ones in the non-brachy group. But later, as we know, we've developed IR devices, which are one-time devices on table, because in brachytherapy, you've got to place the iridium wires and then send the patient to the brachy room, then he comes back again. So it's a bit of a patient movement. But here, when there was an intrastent block, we now had intraductal RF. So we could use intraductal RFA to try and kill tumor inside the stents and try to maintain stent patency, which was done percutaneously in this patient. Benign biliary disease is a major issue. This unfortunate lady had a hepatectomy, and the surgeon did a left hepatectomy, did not realize that the right posterior duct was actually draining into the left duct. So now that right posterior duct had nowhere to go. It was just dangling into a biloma that got drained, and then there was IHBRD and cholangitis. We drained the right posterior sector. So now it was either external biliary drainage, or the patient has to undergo a right posterior sectorectomy, because that bile duct is not going anywhere. And it was intrahepatic virtually, and with dense fibrosis, no surgeon would want to operate. So what we did was that we asked the endoscopist to place an endoscopic stent in the right anterior system. It gave us a target inside the liver. We did a PTBD, and then using the bullseye approach, we put a Dormia basket in the anterior system. We had in the posterior system, we had the endoscopic Dormia in the posterior system. And with the third puncture, we went through and through, connecting the anterior to the posterior. And then after a series of manipulations, we were able to achieve internal drainage of the right posterior, reconnecting it to the right anterior and taking it down the bile duct. So that was a rendezvous. But sometimes a rendezvous has to happen in an extra anatomic location. Post ERCP, biliary issue, bile leak, and this was after a liver transplant. And from the endoscopic side, they just kept falling into the biloma. We said, okay, we'll do the PTBD. So we did the PTBD, and we also kept falling into the biloma. So we said, then let's meet in the biloma. So we also went into the biloma. They also came up there. We got our wires and got connectivity again. And then we were able to achieve internal drainage, and the biloma stopped. And these are liver transplant patients. They are immune compromised. They are sick, very, 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 very precious. So you have to really then manage them. And the surgeons forget what they just want to get the transplant done. They anastomose anything to anything. And then after that, I'm sure Amar and Arun would validate what I'm saying. Then we are left to manage this patient. And if we can't do it, they say, yaar, itna bhi nahi kar sakte. Humne to transplant kar diya, no? Now this patient, they anastomosed one system to the cystic duct. They said, we took the cystic duct for the anastomosis. Gross oversizing. And that tortuous cystic duct, you can see, was definitely not going to flow the way it was supposed to take so much bile down. And the patient would have recurrent cholangitis. So we did a PTBD. There was a bile leak also from that anastomotic side. But don't worry, even these tortuous cystic ducts can be crossed. So we were able to cross it. We just balloon dilated, then put in an internal external catheter, and we kept this for 1 year. And the cystic duct refashioned its anatomy. The valves and all were gone, and it became a single tubular anatomy. And then he stayed inside. Now, this was a patient in whom, again, there was a rendezvous required because our biliary tract was taking us only a certain way. And this post-liver transplant patient had an ascending stricture, which unfortunately involved all the 4 segments of the liver that was grafted. So 5, 6, 7, 8, each of them had strictures. So we had to individually puncture all 4 of them. And then we did rendezvous with the endoscopists to deploy 4 metallic stents individually in each one. But you feel really bad when you have to treat children. This small child, just 1 year old, severe sepsis, jaundice, and hypotensive, comes to the Medanta emergency. And this patient had a stone at the lower end of the bile duct. And there was no endoscopic system to really clear it. So they said, what can you do? So we said, first thing we'll do is a PTBD. So we did the PTBD, drained the bile out. Then they said that the surgeon has to come in and take the stone out. So I said, hold on, not so important. So what we did is we put a guide wire through the PTBD into the duodenum. We went perorally down the stomach and to the duodenum, grabbed our wire. Then we slipped a balloon from the peroral route up the bile duct, did a sweep, and just pulled the stone down into the duodenum. So we were able to clear the stone from the bile duct. This baby did not require surgery. And the main issue, the main problem which was causing all this was solved. Then we took the PTBD out and the baby went home. But stones can happen in the adults, and the key to tackling stones in adults is to gain access to the multiple bile ducts where there is a heavy hepaticolithiasis load, puncture as far out in the periphery as you can, upstream of the stones, which you can then really clear out. We were strong proponents of the percutaneous jejunostomy. We established this as a method to gain access. You do a jejunopexy, then in the efferent loop, then climb up that loop, go to the hilum. It's much easier to pull stones out than push. Though not all of us, I think, agree to what I'm saying, but I'm one of those believers. And now you can see that heavy stone load on top. You can see virtually every segmental duct has stones. All of this had to be cleared. So coming from below, you can really go selectively into whichever biliary segment you want. And that's at the end of it. After a series of interventions, all the biliary systems are cleaned out. All the stones are really washed out. We sometimes have to clear the big central stone first. And this is a cholangioscopic assisted laser lithotripsy that we did to break one big stone at the anastomosis. And a lot of sludge then just flows out and washes out. And this is electrohydraulic lithotripsy. So we have now the facility of using both lithotripters. So this is one that we just did about, I think, 3 weeks ago. Broke that huge fragment, that big stone. And then once you break the big stone, all the fragments can then be pulled out. Again, a patient in whom sometimes internal drainage is required. And this was, again, coming back to SGPGI days. Now, we just couldn't internalize the left side, though we were able to internalize the right. So we didn't want to send the patient home with external drain on the left. So inside the liver, correlating with CT, we punctured from segment 4 to the right duct. And we created an anastomosis from the left to the right above the metallic stent, as you can see. So the left was draining now into the right, but draining through an intrahepatic bridge. And this patient, who unfortunately had a trauma at surgery, but the surgeon was very good. He wrote to us and he said, right hepatic duct has been hit with a harmonic blade because it came in contact with it and they felt that it was traumatized. And absolutely so. This was the cholangiogram. It showed that this bile duct was dilated, had nowhere to go. We did the PTBD. And as you can see, many of you would realize that this is not the bile duct. We've gone into the duodenum probably from post-bulbar D1, which is a very common fistula site. So don't hesitate to use fistula sites for internal drainage. They can be matured, and this patient was salvaged in that manner, as was this patient, in which all the biliary systems went through a sinus tract. And this is not anatomic bile duct, because you can see this is not bile duct region where the catheters have been internalized and they've gone in. This patient, again, unfortunately, had a large mass in the biliary hilum. We did the biliary reconstruction thinking that we'll just do it like we do all our hilar reconstructions, but this one, we just couldn't go down what to do. Now we've got multiple PDBDs and patient is stuck with catheters. So we decided that we'll do an internal drainage towards the left. And from the left, we punctured out into the stomach. A hepaticogastrostomy was created. We punctured into the stomach, put a covered biliary stent from stomach to the bile duct. And that's what it looks like on CT. You've got now internal drainage happening from the liver to the stomach, reconstructed the hepatic hilum, and then exited the patient. You've got to make sometimes these funny shapes. If you're going from the right to the left to do this, it can be very boring for some people who are watching. And this you can see is one of our hepaticogastrostomies that we were doing in SGPGI. I can see Raghu there, and I can recognize Dr. Shivkumar. And I think that's Namrata in the middle. And I don't know who the lady with the mask is. That may be Sister Peter, if I'm not wrong. Is that right? Okay. So here was a patient in whom we kept falling into a biloma after liver transplant, and we just couldn't get in. We couldn't find our way down. We couldn't do anything. So what did we come up with? What we realized is that in a life-related transplant, the stomach invariably moves higher to the right and sticks to the cut surface. So we said that let's go transgastric, and through the stomach, we punctured through and through into a snare that we had placed in that biloma, which we were falling into. So we were able to create a hepaticogastrostomy this time to the stomach in this liver transplanted patient at the central region, at the hepatic hilum. These are the parts which are the dangerous parts. In a transplanted liver, you're not doing a peripheral hepaticogastrostomy, you're doing a central HG where the main artery, the main portal veins are entering the graft. Magnetic compression anastomosis, if it becomes routine, it looks like a very exciting method and a very easy way to establish these anastomosis. But once you've managed benign biliary stricture, you want to mature these strictures. So we often have an indwelling time of 1 year with multiple catheters as per the ERCP protocols, multiple balloon dilatations. And there are different institutions that follow different protocols. Some do repeated balloonings. We do one-time full ballooning and then maintain catheters for a period of time. But to shorten that, now we have metallic stents which can be placed and pulled out. So here you can see one metallic stent deployed from the left side, two PTPDs stayed in from the right, and then you just go in through the PTPD tract after, say, about 2 months, catch the top of the metallic stent, and you can just pull it out through your PTPD tract, and the patient then need not stay for a year. We are believers in biliary manometry, though I know it's not a standardized technique, and I myself am still not clear in my mind whether is it just a waste of time or should we continue to do it. But we continue to do it just because of protocol and nothing very much else. And this was again a patient in whom multiple balloonings were done, multiple PTPDs were done. And there are different stents now that are available that are retrievable. And this is what one of the stents look like. And it's good to have a PTPD catheter placed through the removable metallic stent, because these are fully covered stents. They can slip, and you don't want it slipped and going down the gut. But then after 3 months, if you're happy with your biliary anatomy, you can just fish it out again the way this was fished out, just to show you a picture of what it looks when it comes out. But won't we love this? Won't we love a biodegradable, totally inert, non-clogging biomembrane on a biodegradable framework? Isn't this what we all aspire to see for benign biliary strictures? So we have the polydioxanone stent now, which is a biodegradable biliary stent. It's still working its way through to find its place, to really decide who are the right patients for this. This is one of our patients. You can't see this stent. You can just see the markers on either end. And you have certain time, you know, the degradation time of these stents in different body fluids. That's been tested. And so this can be used in patients in whom there is no reason to keep catheters internally. So all of this has happened, and then there are drug-eluting stents, and then there are some drug-eluting balloons. We've done some preliminary work on using drug-eluting balloons in benign biliary strictures to see whether it will reduce fibrosis and enhance patency of HJ strictures. But if it can be boring, can happen, and this happened in SGPGI. Now, I would, if Mr. Vaidya is sitting here, and if he can recognize who the gentleman at the back is, but a very sincere technologist, because it's so painful to watch somebody twiddling away with catheters and guide wires and taking so much radiation. But yet, the technicians with us definitely are part and parcel, as are our nurses who scrub along with us, and the whole group actually makes the system work. That's Dr. Joseph Roche, with whom we attended a workshop, a TIPS workshop, and it was also a fallopian tube workshop. He's one of these, the pioneer of the TIPS procedure. And in between, you can see that's Dr. Murthy Tadavarthi, who wrote that famous book on interventional radiology. I think it was a Bible during our times, and I don't think it saw an edition after that. But it was a book that was absolutely a complete referral package for anything that you would need. So this was a meeting that was happening in Japan, where we were all attending. It was one of the early interventional radiology meetings there. But not all of IR is only hard work. Like somebody was saying that I was always spending all my life in the department itself, but that was not true. We also had our light moments, and this was also some recreation. That is very important to rejuvenate ourselves, so that we can keep at it and keep working and doing the best that we can for our patients. And I think no oration, especially in SGPGI radiology, can be complete without talking about Dr. Gujral, Dr. Fatke, and Dr. Sunil, and the atmosphere that was in the department at that time. And I'm sure it'll be even better now. But the ability to work and to create your own space, and the acceptance of the whole unit that what you were doing may be crossing the line at times, but it was in the interest of the patients. If that was the underlying parameter in which all of us were pushing our skills and ourselves, trying to establish specialities and our roles, it was taken in good stead. And I think the camaraderie there at that time was something which was unique amongst all of us. And that really has made us establish IR and contribute to whatever little we could to really set up SGPGI as one of the leading institutions for interventional radiology, and from which so many of the young IRs, and maybe now, if I might say, not so young IRs sitting on the front row, are now our teachers. And like I started my presentation today they are our teachers, and we must listen and aspire to them. And the group below is the group of young consultants who were with me at Medanta. Out of them, one is away in America, one is in Australia, one is leading the IR services at RGCI, and Anubhav still stays with us. So thank you all very much, and it's been a pleasure to come here and to interact with all of you, and it's just a wonderful occasion. Thank you all.